Teaching Module 2, Advanced Practice Skills. This is the mnemonic for MSE, Mental Status Examination. It's a full examination. A beautiful mental status always pleases customers, provided, of course, it's justified. Appearance, behavior, motor, speech, affect, mood, thought process, thought content, perception, orientation, cognition, insight, judgment. Now going over each section of this mnemonic with a little more detail. Appearance. Assess a patient's appearance, grooming, eye contact, motor activity, and demeanor. Behavior. Level of alertness, cooperation, rapport, eye contact, level of activity, psychomotor retardation, psychomotor agitation. Motor. Motor tics or waxy flexibility, catatonia, extrapyramidal symptoms. Speech. Level of verbality, absent prosody, pressured, trouble speaking at all, slurred, observing speech rate, volume, and coherence patterns. Affect mood. The outward expression of their mood, observing if it's congruent with the stated mood. Euthymic, dysthymic, euphoric, irritability, angry, playful, suspicious, labile, blunted. Range, full, narrow range, labile with rapid shifts, blunted with a lack of emotional expression. Thought process, linear and rational, analyze how a patient organizes thoughts and ideas. Tangentiality, when patients respond with irrelevant answers that never reach the main point. Circumstantiality, excessively detailed explanations that eventually reach the intended point. Thought content refers to the substance of patients' thoughts and ideas, which may include obsessions or compulsions, persistent intrusive thoughts or behaviors, overvalued ideas or preoccupations, intense fixation on specific concepts, suicidal ideation or homicidal ideation, thoughts about self-harm or causing harm to others. Perception. False perceptions in the absence of any external stimuli, hallucinations. Auditory for schizophrenia. Visual for non-psychiatric conditions like delirium. Orientation. Person, place, time, and purpose. Building and floor number. City, state, day and date. Cognition. General level of intellectual ability, memory, attention, knowledge, and executive functioning. Spell world backwards. Count by fours. Recite days of the week backward. 5-digit number reversal. Who is president? 3-item immediate and 5-minute recall. Count backward from 65, stop at 49. Insight. Schizophrenia alters insight, believing things not consistent with reality. Do they understand they are ill? Do they recognize the value of treatment? Judgment. Evaluating their understanding of situations and decision-making capability. Alcohol impairs both insight and judgment. What would you do if you saw smoke in a theater? Now we move on to the MMSE, the Folstein test. This is Dr. Lopez mnemonic. ORRAL23RRWD, oral 23 RWD. Brief, used to assess cognitive impairment and suspected dementia, measure cognitive changes. Orientation, recognition, recall, attention, language, 2 and 3, 2 objects, follow a 3-step command. Registration, reading, writing, drawing. The mini-cog, neurophysiological test that has been shown to be beneficial in detecting dementia sufferers. Free but not public domain. The mini-cog, 3 words, banana, sunrise, chair. A clock drawing, 3-word recall, banana, sunrise, chair. High yield, non versus public domain scales. MoCA, Montreal Cognitive Assessment, not public domain. SLUMS, St. Louis University Mental Status Examination, public domain. The MMSE Cognitive Screening Test, orientation, recognition, recall, competency, not capacity, not public domain. Mini-cog, free, but not public domain. With the SLUM and the MMSE, a high score is good. MMSE, 24 to 30, normal. 20 to 23, mild delirium or dementia. 10 to 19, moderate. 1 to 9, severe. 0, profound. SLUM, 27 to 30, normal. 21 to 26, mild. 0 to 20, dementia. A. Therapeutic relationship. Definition and purpose. Mutual, interactive, interpersonal relationship between patient and nurse. Focuses on patient-identified needs. Patient-centered approach. Needs and goal-oriented, not the diagnosis. Promotes patient engagement and satisfaction. B. Key components of therapeutic relationships. Genuineness. Being open, honest, and transparent in interactions. Example, nurse admitting they need more information to answer a patient's question better. Acceptance, recognizing each individual's unique experience, beliefs, culture, and background. Example, nurse respecting a patient's religious views on medical treatment. Non-judgmental attitude, removing bias, prejudice, and personal opinions from clinical interactions. Example, nurse providing care to a substance abuse patient with respect and without judgment. Authenticity, creating trust by being genuine, honest, and maintaining professional boundaries. Example, nurse avoiding excessive self-disclosure during a conversation with a patient. Empathy, demonstrating understanding of patients' feelings or emotions without imposing personal beliefs or emotions. Example, nurse acknowledging the pain of a grieving family member while providing comfort. Respect, valuing the dignity, autonomy, and individuality of each patient regardless of their background. Example, Nurse requesting consent from the patient before performing any procedure. C. Managing transference and countertransference in therapeutic relationships. Transference. Definition: patients displacing feelings for significant people from their past onto healthcare providers. It has a potential impact on therapeutic relationships. Example: patient becoming angry at a nurse because of unresolved feelings toward a past caregiver. Strategies for managing transference in nursing practice. 2. Countertransference. Definition: healthcare providers transferring their feelings, emotions to patients. Potential impact on therapeutic relationships. Example: nurse feeling intense emotion or anxiety with a particular patient due to internal issues unrelated to that patient, sees the patient as a past aggressor. There are strategies for managing countertransference in nursing practice, like ask a colleague for assistance. A nice graphic from the PDF. Therapeutic communication is sending and receiving info between two people. The clinician and the client exchange information, especially for clients experiencing emotional distress. This allows collaborating effectively, promoting physical and psychological well-being of clients, and client-centered relationships with trust and respect. Suicidal risk factors. Suicide risk factors. Prior suicide attempts. The single most important risk factor. Remember, first may not be the last. Age-related risks. Males older than 45, females older than 55. Relationship status. Divorced, single, or separated. Think DSS. Ethnicity. Caucasian individuals, Native Americans. Mental health concerns. Presence of a psychiatric disorder. Number 1, schizophrenia. Health complications, chronic or severe physical illnesses. Substance use issues, abuse of drugs or alcohol. Family background, history of suicide in the family. Experience of loss, recent bereavement or life-altering event. Gender considerations, male at higher risk than females. We have a handy mnemonic that covers most of these. SPAMWRAP, SPAMWRAP. Suicidal attempt, psychiatric or physical. Age, marital status, white, recent loss, abuse substance, preferentially male. Clozaril for schizophrenia, lithium for bipolar. Remember, Native American has highest incidence by race. Schizophrenia has highest incidence by diagnosis. Substance abuse. Substance use disorder assessment tool is CIWA scale. CIWA-AR. Clinical Institute Withdrawal Assessment of Alcohol Revised. It's used to assess alcohol withdrawal, determines medication administration for alcohol withdrawal and detox. Alcohol withdrawal symptoms produces a wide range of symptoms. These symptoms follow a general timeline and are commonly classified by 3 stages. Stage 1, mild symptoms. Stage 2, moderate symptoms. Stage 3, severe symptoms. Stage 1, mild symptoms. Within 6 to 12 hours after the last drink. Symptoms involve changes in behavior and mood, and minor physical side effects. They mimic a hangover. Unclear thinking, headaches, dilated pupils, nausea, vomiting, loss of appetite, and minor hand tremors. Other symptoms you might see: anxiety or stress, depression, irritability, mood swings, restlessness, unusual lack of energy, clammy skin, excessive sweating, insomnia, and nightmares. Stage 2, moderate symptoms, within 12 to 48 hours after the last drink. Symptoms are more intense and create abnormal vital signs. Medical supervision is important. Seizures may begin during this stage. Mental confusion, hallucinations, increased blood pressure, irregular heartbeat, breathing difficulties, and seizures. Stage 3, severe symptoms. Within 48 to 72 hours into the detox process, seizures and hallucinations can progress to delirium tremens, a life-threatening condition. Agitation, disorientation, hallucinations, mainly visual, rapid heartbeat, excessive sweating, and fever. High-yield information. CIWA score thresholds for treatment initiation. Treatment starts with a score of 8+ for PRN meds. A score of 15 or higher is PRN meds and scheduled meds, diazepam and lorazepam. Preferred medication for patients with liver diseases and alcohol withdrawal management, lorazepam. Liver lover lorazepam. And remember the older mnemonic outside the liver: oxazepam, temazepam, and lorazepam. FDA-approved medications for alcoholism and their main benefits: disulfiram, acamprosate, and naltrexone. DAN. Treatment starts with a score of CIWA 8+, PRN. CIWA score of 15 or higher, PRN and scheduled meds. DAN benefits: reduces alcohol consumption and increases abstinence. We have a short mnemonic for disulfiram treatment: DIAL, D-I-A-L. Disulfiram treatment: initiate after 12 hours alcohol-free. Avoid alcohol products. Liver enzyme monitoring. Some more important facts for the exam. Mechanism of action is aversion therapy. Waiting period requirement 12 hours. Contraindications and interactions: products with alcohol. Potential side effects: liver issues. Must wait 2 weeks after stopping disulfiram to continue alcohol again. It increases accumulation of acetaldehyde, causing unpleasant symptoms. Now we move on to opioids. The COWS screening, COWS, Clinical Opioid Withdrawal Scale. It is designed to evaluate the severity of opioid withdrawal. It's a rating scale to assess withdrawal symptoms, and it guides appropriate management and treatment. Symptoms of opioid withdrawal are summed up in the mnemonic flappy hands, FLAPPYHANDS. Fever and chills, lacrimation, agitation, piloerection, pupillary dilation, yawning, hypertension and tachycardia, aches, nausea, diarrhea, sweating. The COWS scale: 1 to 4 is no withdrawal, 5 to 12 is mild, 13 to 24 is moderate, 25 to 36 moderately severe, over 36 severe. Mechanism of action is an aversion therapy. 5 to 12 points, mild withdrawal. Consider clonidine. Example, person experiencing occasional yawning and mild anxiety. 13 to 24 points, moderate withdrawal. Use buprenorphine or Suboxone. Example, individual with muscle aches, sweating, and difficulty sleeping. Recognize the counterintuitive nature of pinpoint pupils. This reaction is counterintuitive because one might expect a depressant like opioids to relax all muscles, leading to dilation rather than constriction. Instead, opioids trigger the specific neural pathway resulting in pinpoint pupils, which is often a telltale sign of opioid intoxication or overdose. Just a visual representation of the dilated pupils from stimulants like alcohol, the pinpoint pupils, meiosis from depressants like opioids. An example you might see of nystagmus in PCP use, and the red eyes, the conjunctival injection for THC. Now we're going to go over everything depression scales. A little trick with PHQ-9 and GAD-7. They both have a score of 3 points each for 9 questions on the PHQ-9, 7 questions on the GAD-7. So high score is 27 and 21. HAM-D, moderate, is 14 to 18. Edinburgh Postnatal Depression Scale is recommended to screen patients for postnatal depression or depression during pregnancy. PHQ-9, moderate, is 10 to 14. Beck or BDI, moderate, is 19 to 29. The HAM-A, mild to moderate, 18 to 24. GAD-7, mild to moderate, 10 to 14. HAM-A is the most commonly used scale. Some high-yield information. All depression scales, 0 is good, high number is bad. Mild depression or anxiety therapy or nothing. Moderate and above, medication and or therapy. Severe range, assess for suicidal ideation. My grandma went to buy a ham. They cost 14 to 24, but the D ham was only 14 to 18. Vex was crazy at 19 to 29, so she drove to the PHQ-9 where their hams ran about 10 to 14 for both PHQ-9 and GAD-7. Some frequently tested points. Understanding the differences between MMSE, SLUM, HAM-D, PHQ-9, and the Beck scales. Identifying the appropriate scales for specific scenarios. And recognizing examples of mild, moderate, and severe cases in each scale. Delusions. Delusions are a false, unwavering belief despite evidence to the contrary. Understand delusions helps identify and support individuals experiencing mental health challenges, persecutory and grandiose. Everything you need to know about referential thinking. Definition: irrational thoughts about personal connection to random events or objects. Recognizing referential thinking can aid in diagnosing various mental health conditions. REFER, refer. Really, everything feels extremely related. Delirium. Delirium is a syndrome, not a disease. It has a 40% mortality rate within 1 year. Delirium is a syndrome, not a disease. It causes short-term cognitive changes. Acute onset causes short-term changes in cognition. An example, sudden confusion or difficulty focusing after surgery. The hallmarks, altered mental status, inattention, and acute onset. CAMI, confusion, assessment, method, instrument. It's a tool for identifying delirium in patients. It's quite often used in the ICU. Comprehensive metabolic panel, a CBC, thyroid function, a UA, drug screen, chest x-ray, infectious disease related tests like HIV and syphilis, medications. Haloperidol is preferred for agitated delirium. Atypical antipsychotic agents are an alternative to Haldol. Anxiolytic agents aid in sleep for insomnia patients. Non-pharmacological, safe monitoring and measures, addressing basic needs like food and hygiene, maintaining routine with familiar faces, clock, and calendar present in the living space. The mnemonic for delirium is where the F am I? Where, transient, fluctuating, acute, medical causes, intoxicants. We need to memorize the key differences between delirium and dementia. For delirium, it begins suddenly and develops quickly. It has a defined starting point. It's temporary and reversible. It causes difficulty with attention. It causes slow, slurred speech during the episodes. Where dementia, on the other hand, begins gradually and progresses over time, has an uncertain starting point, is permanent and worsens as the disease progresses, causes difficulty with remembering recent events. It causes speech problems, difficulty putting thoughts into words, remembering common words, and results in the repetition of words and phrases. Some high-yield tidbits. Delirium's hallmark symptoms are fluctuating consciousness and cognition. A 1-year mortality rate for delirium patients is 40%. Delirium versus dementia. Haloperidol is the preferred medication for agitated delirium. Neurocognitive disorder, formerly known as dementia. Dementia is a group of disorders that involve gradual cognitive decline, impacting various mental functions like memory, problem solving, and organization. Main cognitive deficits are impaired executive functions, impaired global intellect, impaired problem solving, impaired organizational skills, and altered memory. Most common for 60-year-olds and older. Types of dementia. Cortical dementia affects language and memory. Alzheimer's, Pick's disease, which is frontotemporal dementia, Creutzfeldt-Jacobs disease. Symptoms are aphasia or amnesia. Subcortical dementia, associated with depression, irritability, apathy, and motor symptoms. Huntington's disease, Parkinson's disease, HIV dementia. Symptoms, extrapyramidal symptoms, dystonia, increased muscle tone. So remember, cortical dementia, language and memory, subcortical dementia, depression and motor skills. Alzheimer's type is a cortical dementia, most common. It has a gradual onset with progressive decline, no focal neurological deficits. Pick's type is a cortical dementia, more typical in men, early stage personality behavior, later stage cognitive changes, Culver-Bucy. Culver-Bucy syndrome is an extremely rare brain disorder that can cause memory loss and behavior problems. Cortical dementia, Creutzfeldt-Jacobs dementia. Cortical dementia and a prion disorder. It's fatal and rapid progression, as transmissible by blood and body fluids. Flu-like symptoms progress to aphasia, depression, psychosis, and death within 6 months. Subcortical dementia is an HIV dementia. Subcortical dementia, prevalent at CDC less than 200 and high viral loads. Early signs, cognitive decline, motor abnormalities, like lack of coordination, motor abnormalities, tremors, dystonia, and ataxia. Behavioral abnormalities, late stage symptoms, mutism, seizures, and hallucinations. Subcortical dementia, vascular dementia, the second most common type of cognitive change at a later stage, and this one is stepwise. Cardiovascular involvement with like high blood pressure, but the hallmarks are carotid bruits, fundoscopic abnormalities, and enlarged cardiac chambers. This is Lewy body disease is both a cortical and subcortical dementia, visual hallucinations, and Parkinsonia. Adverse reactions to antipsychotics. Huntington's disease, subcortical dementia, motor abnormalities, high incidence of depression and psychosis, and then vitamin B12 deficiency, folic acid. It's rare but potentially reversible dementia. Prioritize non-pharmacological interventions. First-line agent is atypical antipsychotics. Avoid benzodiazepines because of the risk of falls and delirium. FDA-approved medications for dementia. The cholinesterase inhibitors, donepezil, rivastigmine, galantamine. The glutamate regulators, memantine, or a combo, cholinesterase inhibitor with glutamate regulator, donepezil with memantine. The mnemonic for major neurocognitive disorder or dementia is DIRE, D-I-R-E. Decline in cognition, impairment, rule out delirium, exclude psychiatric. Basic symptoms of dementia are impaired executive function, impaired global intellect, impaired problem solving, impaired organizational skills, altered memory. The basic differences between cortical and subcortical. Cortical is language and memory. Subcortical is depression, irritability, apathy, and motor symptoms. Dementia of Alzheimer's type is referred to as DAT. It's a cortical dementia. It's the most common type. It's gradual onset with progressive decline. No focal neurological deficits. acetylcholine deficiency, and diffuse cerebral atrophy. Frontotemporal dementia is cortical dementia called Pick's disease. More typical in men, early stage symptoms, personality, behavior, and language changes. Cognitive changes at later stages, Culver-Busey syndrome possible. Acetylcholine deficiency and diffuse cerebral atrophy. Creutzfeldt-Jakob dementia. Cortical dementia, prion disorder. Fatal and rapid progression. Flu-like symptoms progress to aphasia, depression, psychosis, and death within 6 months. Transmissible by blood and body fluids. HIV dementia. Subcortical dementia, prevalent at CD4 less than 200 and high viral loads. Early signs, cognitive decline, motor abnormalities like lack of coordination, motor abnormalities, tremors and dystonia, ataxia, and then behavioral abnormalities. Late stage symptoms, mutism, seizures, and hallucinations. Lewy body disease, both cortical and subcortical, visual hallucinations. Parkinson's features like bradykinesia and tremors, adverse reactions to antipsychotics. Vascular dementia, both cortical and subcortical, the second most common type of cognitive change at a later stage. Cardiovascular involvement, high blood pressure, but that's not its hallmark. The hallmark is carotid bruits, fundoscopic abnormalities, and enlarged cardiac chambers. Huntington's disease, subcortical dementia, motor abnormalities, high incidence of depression and psychosis, vitamin B12 deficiency and folic acid. Cortical and subcortical are affected by B12 deficiency, rare but potentially reversible dementia. Do not confuse cortical and subcortical dementias. Know dementia types and symptoms. These last few slides are key points I got while taking the question bank questions on this module. Barcoding medication administration, BCMA. The use of a scanner to identify medication ordered in an electronic medical record and administered to a patient. Morbidity rate. The morbidity rate describes the rate at which a given disease is present in a population. Relapse determinants. In the relapse prevention model, both immediate determinants and covert antecedents increase the risk of lapse and relapse. No examples of intermediate determinants. Covert antecedents. Rationalization, emotional dysregulation, compulsive thoughts, subtle shifts in attitude, unconscious triggers, resentment or grudges, false sense of control, lack of self-awareness, overconfidence of recovery, isolation of emotions. Intermittent determinants. Environmental cues, negative emotions, peer pressure, lack of support, poor self-care, mental health issues, overconfidence, unresolved trauma, boredom, coping skills. Expanding interventions. Clarifying involves the summarization of what the patient said and seeking clarification for accuracy. It is an expanded psychiatric interview technique. GAD-7. GAD-7 is a 7-question generalized anxiety screening tool. Zung's anxiety scale, the Hamilton Rating Scale for Anxiety, HAM-A, and the Yale-Brown Obsessive Compulsive Scale, YBOX, are all standardized rating measures for anxiety. Forensic PMHNP. The functions of the court system, litigation, procedures, workings of the criminal justice system, relevant case law and health litigation, mental health and distorted thinking patterns and impaired cognition, safety, security, management, and risk assessment of individuals. The primary knowledge base for forensic PMHNPs does not include understanding the rights of the accused, nonverbal cues of the accused, or proper physical assessment of victims. Risk assessment. There are 2 types of risk assessment. Forensic risk assessment protects the public from persons with known mental disorders and dangerous histories. A risk assessment is a psychiatric evaluation performed in an emergency department after an arrest and before the person is confined to corrections. Forensic nursing. In forensics, the nurse-client relationship is based on the crime committed and investigational aspects of the interaction. Shingles. Anyone over the age of 50 should be vaccinated.